research that exists. When Dr. Lapidus talked about her definition of translational research, everything was around T1 and the very, drug development and going backwards and forwards around T1. We're here today to say where do the other translational research come in, and I've asked Dr. Perfetto to say a few words about her background because she also comes from a pharmaceutical background, but in a very different type of translation.
I thought you were saying it's because I can't keep a job.
No, not at all.
Okay. So I'm going to talk about health services research. I'm going to give you my background. I actually started career-wise as a pharmacist. And so I worked as a pharmacist in what's known as the Indian Health Service as part of the Public Health Service. And I did that for about 6 years. And when I was working in the Indian Health Service, I became exposed to an epidemiologist that I worked with out in the field. And so she was an epidemiologist who worked for the CDC, but she worked on the same reservation that I worked on. And I got to understand what epidemiology was. And I thought I knew I wanted to go back to graduate school at some point, but I really didn't know what for. And I became introduced to epidemiology. So back to graduate school, I got my Ph.D. at the University of North Carolina, the School of Public Health there, and my background is health policy and epidemiology. After I graduated with my graduate degree, I wanted to go back into the public health service, but I wanted to do research instead of clinical practice. And am I on?
Stacy has asked me to check your mic.
Okay.
No, you're not on.
I'm not on. Oh, okay.
Now you're on.
Better? Same.
It's the same for them, but not.
Okay. Oh, okay. All right. Okay. So went back to the public health service after graduate school and worked at what was known as it's called ACPAR, the Agency for Healthcare Policy and Research. Anybody know what that is? It's what's known as AHRQ today, Agency for Healthcare Research and Quality. So AHRQ went through a little bit of a dismal period where no one on Capitol Hill liked them and they wanted to kill them off. And their survival tactic was to change their name. So I worked there under the old name. And I worked there on a program that was a brand new program, and it was called the Medical Treatment Effectiveness Program, to look at what's now called comparative effectiveness, which was then called medical treatment effectiveness. And I was hired because I was the lone pharmacist in the agency because they had in their legislation that formed the organization, there was one sentence that said that there were priorities, and one of the priorities was that they should look at the effectiveness of prescription drugs. And so I was hired to start a program that would handle that sentence so that the administrators could check the box and say that they had met what they were supposed to do for all of what the legislative requirements were. So I worked there, and it was the advent of what became known as outcomes research, when outcomes research really became the hot topic. And AHRQ, at that time, ACPAR, was the place that was funding all of that kind of research. And I did a program on pharmaceutical outcomes research, and that was the program that I was responsible for. But because it was so hot, and there was this aura about it that, the government is doing this, and the government knows everything about it, and if you're the industry, you better go buy some of that, because if you don't have it in-house, then somebody's going to figure out a way to use it against you in some way. So I was one of the many people who got recruited into the pharmaceutical industry to start an outcomes research group. So I worked for a company called Wyeth Ayerst, which doesn't exist anymore because, like Pfizer, the Pac-Man of all pharmaceutical companies, has gobbled them up over the time, and Wyeth became one of the companies that Pfizer bought. So I worked for Wyeth. I started the outcomes research group at Wyeth, and then subsequently worked for other companies. I worked for Pfizer. I worked for some consulting companies, all centered around this idea of outcomes research, pharmacoeconomics, medical treatment effectiveness around the pharmaceutical area, now more fondly known as comparative effectiveness research, but with an industry slant on it. It's strictly looking at pharmaceuticals, where CER now is not really solely a pharmaceutical approach. It's looking at every kind of service that you provide. So that's my long sordid history. My last tenure was 7.5 years working for Pfizer. I worked in clinical research. I worked in the outcomes research group, which is part of the medical department. And then because of my healthcare background, because of my health services research background, epidemiology, and health policy, I was transitioned into a unique position where I was a liaison between the company and the research end of it and the government organizations that do research that's affiliated with things like comparative effectiveness research. So I was the company liaison to AHRQ, the IOM, the National Quality Forum, Pharmacy Quality Alliance, and things that would come out of organizations like CMS and other government agencies and HHS. My job was to translate what's the government doing and how could it affect the company or a product line or a therapeutic area, and then vice versa. What were we doing in a therapeutic area or on a particular drug that we should bring to those other organizations to let them know about, because we had information that they might want. So that was my job, was to be that policy research interface and to be able to translate the policy implications for the company and the research implications for the policymakers. I got tired of that and decided that I hadn't tried academia yet, and so here I am. And I've been here for an entire year now, and it's gone by pretty quickly, I can't tell you. So I'm going to talk about health services research, and we're going to do a little walk down the memory lane of health services research so that you have the history of health services research and what it's about, where it came from. So we'll begin with the objectives for today, an overview of health services research, definitions, and there are a lot of them. Everybody has had their own definition of what health services research is over the years. Discuss the intersection of health services research and epidemiology and policy, and then give you some actual tangible examples. And many of these are historical examples. They're older examples, but they're the classics. They're the ones that everybody knows about and hears about and have been the highlight of a lot of policy making and clinical decision making over the years. So first we throw out the acronyms out there, because you know that every discipline has its alphabet soup, and health services research is no different. So you'll see we've got PCOR, patient-centered outcomes research, one of the latest buzzwords, along with PCORI, AHCPR, what's now AHRQ, Agency for Healthcare Policy and Research, what it was years ago. ARA legislation, the Centers for Medicare and Medicaid Services, and somehow they turned into CMS and they got rid of one of their M's and nobody really knows what happened to it. But so this is the alphabet. If you find me throwing out an acronym and I didn't explain to you what it is, just call me on it and let me know, because it's very easy when you've got these many letters flying around to let a few of them fly uncontrolled. So the historical context of health services research. It's a relatively young field. It hasn't really been around all that long. It was developed and evolving since the 1960s forward. It wasn't until like the late 80s, early 90s that it actually got recognized as a discipline, and you started to see Ph.D. programs in health services research. So it's still relatively young compared to many other disciplines. Think about the evolving healthcare system. Okay, so it makes sense that something like health services research would have happened around the mid-1960s, because that's when there were a lot of hot policy things that were happening in the provision of healthcare and coverage of healthcare services in this country. Medicare and Medicaid got funded in the 1960s, the great social experiment. And so it made sense for the government to say, how are we going to figure out whether or not we're getting what we're paying for when we're putting money into these programs like Medicare and Medicaid? So that you can see how the evolution of that would have happened. So in the federal government, a health services research study section was established for grant applications. In 1969, the National Center for Health Services Research was established. And that is the original organization that eventually became ACPAR and then became AHRQ. So it's gone through a number of changes over time with different legislative initiatives changing its name and expanding what it does and the purview of what it does. In 1972, there was a report of the Panel on Health Services Research and development of the President's Science Advisory Committee. So you can see both of these in 1969, 1972, they were both setting out some of the first definitions that you would see on health services research, a field that develops methods for improving access to care, moderating the rate of Medicare prices, and assuring the effectiveness of care. So even in 1969, we were talking about cost, access, and effectiveness. Okay? So that it hasn't changed a whole lot. The report said health services research seeks to improve the network for providing health care so that the fruits of biomedical research are readily available to all of its citizens. We had someone who was very poetic writing the definition at that time. But it still gets at the idea of, are we going to get bang for the buck? 79, an Institute of Medicine report. Health services research is the inquiry to produce knowledge about the structure, process, and effects of personalized health services. And in 1995, the Institute of Medicine, a multidisciplinary field of inquiry, both basic and applied, examines use, costs, quality, accessibility, delivery, organization, financing, and outcomes of services to increase knowledge and understanding of the structure, process, and effects. So it starts to be this amalgamation of all the previous definitions. And so you can see this over this 20, 30-year period of time, the definition was evolving, but the core of it, access, quality, were the kinds of things that people were still getting at. Were we getting at the effectiveness and access to care and the cost of care? 1979, you see structure, process, or effects related to a conceptual framework other than that of contemporary applied biomedical science. Structure, process, effects, the recurring themes. Cost, quality, accessibility, delivery, structure, process, recurring themes. Multidisciplinary, again, access, quality, cost, health and well-being, the outcomes. So you see that's all the recurring themes that have been coming through. Even as late as 2002 with Kathy Lohr, how people get access to care, how much care costs, and what happens to patients as a result of the care. An ARC definition from 2002. And this is probably one, Kathy Lohr and Don Steinwalk's, where it's been repeated many, many times. So you get the picture of what this is about. It's taking a look at those care in practice. And it's been very often been said, care in the real world. What happens when care is provided in the real world? But again, there are some fundamental issues. And you'll very often hear that health services research focuses on cost, quality, and access. I've thrown utilization in there too because I think that cost and utilization get interchanged with one another. When you're in a political scenario where it's taboo to talk about cost, they'll start to talk about resource allocation or use of resources. Fundamentally, that comes down to spending money when you're using resources. So utilization can very often be the euphemism that gets thrown in there when someone doesn't want to be so crass as to use the dollar and cost word. So health services research is as a discipline. In order to really be recognized as a discipline, as you saw in one of the definitions, there's a conceptual framework that's different than a traditional biomedical framework. And so I wanted to just introduce to you this idea of some of the conceptual frameworks that you'll see used in health services research. And they're very fundamental. If you talk to anyone who has their Ph.D. in a health services research discipline, the very first thing that they will talk to you about is Anderson and Newman. Everybody learns the Anderson and Newman framework. And you'll see, I gave you some citations here where you can see the very first presentation of the framework and how it evolved over time. But essentially, this is the 1973 most basic conceptual framework was used by Anderson and Newman and introduced by Anderson and Newman. It's been tweaked over time. But basically what it says is there are social determinants, health system determinants, and individual determinants that get to how many services and how a person uses these services. Now, what's the most important thing that's missing off of this original 1973 framework? I think cost is in there as part of the resources. But outcomes, right? What happens to the patient? So you've got characteristics of the patient, predisposing illness, their level of illness, whether or not they have money and can get access to care. The social determinants, that's really kind of like what are the available treatments that we have now? What's the system of care looking like? And then the resource utilization for the healthcare system. But nowhere in here does it tell you what happened to the patient at the end. So they this was early. This was before we started having a lot of discussion about structure, process, and outcome. And so it got left off. So over time, this model has been tweaked. In 1995, Ron Anderson published this version of the model, and this is where he started to be a little bit more comprehensive and really capture all those little pieces that everybody was talking about in the definitions that I just presented to you. Excuse me. So the environment, the characteristics of the population, the behavior of that population, and then the outcomes that come from the services that were provided. But those outcomes are dependent upon the personal characteristics that that patient has, where they receive care, the clinicians they receive care from, whether or not they have access to care. So all those things got built into this newer model. So again, as a discipline, disciplines are typically recognized by the conceptual models that they use, and this is one of the fundamental frameworks that gets used in health services research. Another conceptual framework that is often referred to is that of structure, process, and outcome. And this was something that was written by Avidas Donabedian, and this was back in 1966, and it's still very fundamental today. What he said was, if you're going to measure the quality of the care that someone's getting, or measure the quality of the services that were provided, you have to do it in three ways. You can't do it in just one of the three, because then you get a very incomplete picture. You've got to do all three. Structure it's the nouns of healthcare. Is the structure there? Are there doctors? Are there nurses? Is there a hospital? Is there a clinic? Does the clinic have staff? Does the clinic have the equipment that it needs? Does it have the drugs in the pharmacy? Does it have the lab to do lab tests? So it's the bean counting. Okay? It's, do you have all these things that give you the ability to provide care? Process is the verbs of healthcare. It's, what are you doing with all that structure, and how often are you doing it? So it's counting up. How many EKGs did you do? How many cardiograms did you do? How many patients got seen in a day? How often was a particular piece of machinery cleaned? So structure is, you had the piece of machinery. Process is, how often it got used in one day, and how often did that piece of machinery get cleaned or serviced or whatever needed to happen to it. None of that tells you whether or not anyone got better. That just tells you that you had the capability to provide a service, and you provided the service. Was anybody better off for it? Outcomes are changes in health status that you can attribute to the care that was provided. So Donabedian said, you got to have structure, you got to have process, and you got to have outcomes. And you could be measuring any one of those three things. It's going to give you a very incomplete picture. You've got to measure all three to understand what did you do, what did you do it with, how did you perform that service, and was anybody better at the end of the day? Now you see I put outcomes in little parens there because it is very rare that you would have one outcome. You know, death maybe might be the one time you'll have one outcome, but typically you will have multiple outcomes. You won't have just one thing that will happen to people. And so while the conceptual framework was originally phrased as structure, process, outcome, measure, structure, process, outcome, we're usually measuring more than one outcome. And it's important to keep in mind, because when you start to think about the outcomes of care, you can have a lot of controversy about which ones are the right ones to be measuring. And right now, with a big focus on patient-centered outcomes research and PCORI, the Patient-Centered Outcomes Research Institute, the thinking is we've been collecting a lot of data on outcomes over time, but are they the outcomes that patients care about? So, you know, when you're deciding, you know, if you want to do a study and you're deciding on what the endpoints of your study will be, you're trying to pick the right outcomes. PCORI will tell you that unless you had patient input into helping you pick those outcomes, you have a good chance of picking the wrong ones. So health services research as a discipline, again, gets to what kind of research and data do you tend to use in this kind of research. And you will see that very often this falls on quasi-experimental and observational study designs. So very rare that you'll see a randomized controlled trial in health services research. And I'll talk a little bit, I'm going to give you an example of one, and I'm going to talk a little bit more about why you rarely see them. But traditionally, you're going to see systematic reviews and meta-analyses, so very formalized review of the literature, not a literature review where you just, where it couldn't be replicated. Formalized reviews where you actually know what someone did so that you could replicate the methodology if you wanted to. Databases, observational databases, claims databases, surveys, registries. It's a very common source of data for health services research. The Medicare database, many state Medicaid databases, many databases that health insurance companies have available because of the claims processing that they do. So, you know, United Healthcare database, very big database that gets used. Aetna, Humana, they all have big databases that they use internally for research, and they make available to researchers under certain circumstances. Case mix adjustment is very important when you're doing health services research, and this is one of the things that came out very early on in the early days of CMS when they wanted to report on hospital mortality, and they were going to put out this information about deaths in particular hospitals. And it was a big controversy was, well, wait a minute, a tertiary medical care hospital is going to look worse than a community hospital if you only look at deaths without adjusting for anything, because the community hospitals are sending their worst cases to the tertiary care center. They're going to get all the worst cases. They may be getting them when they've reached a very critical period where they're most likely close to death, and that's why they were transferred in the first place, and yet the death is going to be blamed on that hospital. So things like case mix adjustment became very important in health services research because of those kinds of studies that were being done. And then patient-reported outcomes. And that gets to things like a patient's ability to function, quality of life, all of the kinds of things that you would actually get the information directly from the patient. And that's one of the things that's another big component of health services research, especially now that we're in this advent of patient-centered outcomes research and getting the information from the patients. So it's not only tell me which outcome that you want me to measure, but very often what they're telling you is the outcome I care about the most is how I function or how I feel. And that has to be collected using some very formal processes with patient-reported outcome tools. Also the economic components. So we talked a little bit about cost before and resource utilization, cost benefit, cost effectiveness, cost utility, resource utilization, budget impact analysis, and then very often you'll see some cost studies that are focused on efficiency. And how much more efficient can a system can be if you eliminate the waste out of the system. So overutilization, those kinds of things. These are very often the targets of health services research studies. So again, you get at that cost, quality, and access. So I'm going to talk a little bit about the intersection of health services research and epidemiology, just because most often in health services research we're using epidemiologic methods. Okay? Very common. And I can't tell you that there are methods that are only used in health services research or only used in epidemiology. The lines become very, very blurred. And so a little bit, just to understand that health services research uses the same methods that everyone else uses. They just might use them on different populations or in different ways. So the simplest level is the study of populations, the use of services or care provision. Outcomes, they could be at the patient level or a system level. Costs, you can apply similar methods, but typically you will not see a randomized controlled trial in health services research. Very, very expensive to do these very large studies, and so it's very rare that it happens. And then you're usually looking at studies where the result of the study is going to fundamentally have some impact on a program or a policy that has to do with cost, quality, or access. So the impact, very often one of the things that you'll see studied is the impact of a policy on health services and research and vice versa. So for example, if the government made payment available for something in particular that it had never paid for before. And I'll give you the example in the Affordable Care Act. There was a stipulation in there that preventive services that had been rated by the U.S. Preventive Services Task Force that got an A or a B rating as of the passage of the Affordable Care Act would be available at no out-of-pocket costs, first dollar coverage. So Medicare and privately insured patients now should get for free vaccinations that have a rating or any other preventive service that the U.S. Preventive Services Task Force says has an A or B rating for their evidence. So an interesting health services research question would be to say, okay, what did that do? Making that available at no out-of-pocket cost to anyone. What happened? Did we see utilization rise? Did people go out and get their vaccines or their mammographies or any other things that they needed to get done? Very high. Did the rate go up? If that rate went up, was there a lower rate of pneumonia because people were being vaccinated? Was there a lower rate of flu because people were being vaccinated? Those are the kinds of health services research questions that would result from a policy change. And then vice versa, maybe some new treatment becomes available, and you want to know, did the advent of that new treatment that becoming available, did it change policy for whether or not that treatment was covered? And how long did it take to happen? What was the lag time in seeing that happen? So we can do this in either direction. Most typically, we're seeing what's the implication of some kind of policy change or policy decision that got made. So examples, Medicare, first dollar coverage, Medicaid. We've had a tremendous expansion in most states of Medicaid coverage under the Affordable Care Act. What's going to happen there? We'll see what kind of implication that has for actual patient outcomes. And then the Children's Health Insurance Program, the CHIP and the S-CHIP, which vastly expanded children's health insurance coverage in many states in 2009. So these are the kinds of things that people are studying now because they're these natural experiments. They happened, and we can take a look at the before and after to see what happened, trying to, as best we can, account for the other things that could have had implications for those rates at the same time. And then we also have an interesting mix of state policies with 50, and I say 50 plus different states because in the territories they also have health programs. So with that many different programs, all implementing different policies at the same time, there is the opportunity to compare what happens in states that put something into place versus states that didn't put something into place. And again, with the proper adjustments to try to balance out what other things might have caused that to happen. So and internationally, we also have different models. So you can think about it as you can also do some of those international comparisons. And you see it all the time with why is the death rate higher in some countries versus other countries, and what might be the cause behind some of those kinds of things. So very typical examples of health services research. So let's go into some of the classic real-life examples of health services research studies that have happened over time. The RAND health insurance experiment is one that's very well known. How many of you have heard the RAND health insurance experiment before? Anybody? I got two. I got a nod of a head and a hand. Okay. So the RAND health insurance experiment, it was a controlled trial. It was actually a very large, very expensive study. It was one of the longest and largest studies that was ever undertaken. It started in 1971, and it sought to improve federal and private policy on financing medical services, determining what should be covered and how should it be covered, how much cost sharing, out-of-pocket deductibles, and things like that should be in. So what happened was there were 6 study sites. Families were assigned to one of 14 different fee-for-service insurance plans, and it varied how much the cost sharing was, depending upon what plan you were allocated to. And then some of them were in a prepaid group practice, so a Kaiser Permanente model. There was 70% participation for 3 years. The rest of them stayed in for 5 years. There were 7,691 participants. If you want to look at any of the background on this, there are lots of publications, and if you just look up Joe Newhouse and Bob Brooke, these are people who wrote about this for many years and did many different aspects of the differences between these groups. But the findings were that those paying for a share of their care used fewer services than those that were given straight-out free care. Well, it certainly makes sense. But the question was, did it make a difference? It roughly reduced the use of both highly effective and less effective services in roughly equal proportions. It didn't significantly affect the quality of care received by the participants, and it had no general adverse effects on participant health, except for a few things. Free care led to improvement in hypertension, dental health, vision, and some serious symptoms, selected serious symptoms. But these were the most important. Hypertension was probably the most important. And those improvements were among the sickest and the poorest patients. So this is one of the studies has been used to fundamentally make decisions about out-of-pocket costs, how much people should be paying for their copays and deductibles. And it was well over 40 years ago. I mentioned earlier that we don't very often see randomized controlled trials in health services research, and it's because it is so expensive to study something like 8,000 people over a 5-year period of time to see what happens to them because of a policy change or because of a different copay. It's very expensive to do, and you're putting all your dollars in one basket. You could be putting hundreds of millions of dollars into one study, and if that one study fails, then you've used money that could have been used for other things, smaller scale studies. The environment may change during the experiment, and that's a real risk that you run when you're doing one of these longer term trials. You may start off with a study that had a particular intent or a particular treatment that was being used, and suddenly some new breakthrough happens, and what you were looking at is now obsolete, and it doesn't make any sense to spend that money anymore. It's very prospective. It can take too much time, a long time to get the results, and you really need an interdisciplinary team to get it right. So it's made up of physicians, epidemiologists, statisticians. It's a very broad group. Another example of in access and health disparities is the Jackson Heart Study. It was a $33 million study, and it tracked the incidence of cardiovascular disease among 6,500 African Americans in Mississippi. And this was a study that was very much like the Framingham study. Framingham, everybody familiar with Framingham? There's lots of nods going on now. Again, a very large health services research project. An example on utilization and cost, and this was done by Dr. Magaziner here. An epidemiologic study of dementia among new admissions to nursing homes identified people with and without dementia in a nursing home environment, 59 nursing homes. It matched person-level epi data of the parent study to the Medicaid and Medicare data from that facility. So this was a way of combining data that was actually coming from multiple sources, because it was being collected at the nursing home level, but it was also being collected at the individual level. 640 with dementia, 636 without, tracked 1 year pre-admission and 2 years post-admission. And it showed Medicare expenditures peaked in the month immediately preceding admission, dropped to pre-admission levels by the third month in the nursing home. And there are some publications there if you're interested in more about the study. But again, large-scale project. These are very hard to do and very expensive to do. The VA has numerous health economics resource centers throughout the country. These centers are scattered around. They have a very large health services research program within the VA. Lots of VA studies published in this area, and these are a couple of examples of some of the work that the VA has done. Medicare claims. One of the sources of data that gets used in health services research studies in observational data analyses is to use existing claims data from Medicare. Over the years, the database has expanded. It's very large now. It's become much more refined, and with the inception of the Medicare Part D program, now there's also drug data that's in the database. That wasn't there before. Before 2006, there was no Medicare coverage for drugs. Patients either paid out of pocket or they had Medigap policies that helped them cover their drug costs. And so if you look at data on Medicare patients prior to 2006, there is no drug data, because the drug database didn't exist because Medicare was not covering any of it, so it wasn't paying any claims. After 2006, you'll see that Part D drug data is there, and it really helps give you a much bigger picture, broader picture of the individual's utilization. There are algorithms that have been created, because very often you may want to look for a diagnosis in the Medicare data, and you won't find the diagnosis, but you'll find the drug that gets used for that diagnosis, and it can be a marker for you that that person was being treated. So very often you may not find a diagnosis of Alzheimer's disease, you may not find a diagnosis of a particular kind of dementia, but you'll find Aricept, and that can tell you that the clinician suspects that that person has some level of dementia or mild cognitive impairment, but at the time that they were treating them, the patient was sitting in front of them being treated for their out-of-control cardiovascular disease, their CHF, their diabetes, their hypertension. Since those were the more immediate, those were the three diagnoses that got put up front, and maybe dementia's falling to the bottom, so you pick it up with the drug data. So another way of conducting health services research studies using the Medicare data, but also some of the things that you have to impute, because you are using claims data, and it is a more complicated way of going about it, and it can be much more inexact science. So this was a study to show how the intensity of anti-diabetic medication regimens for Medicare beneficiaries varies by level of medical spending. And the results show that high-cost Medicare beneficiaries with diabetes receive substantially less intensive anti-diabetic regimens compared with those incurring more modest medical expenditures in the year 2002. So leading you to think, well, more intense treatment, or better treatment for those diabetes patients can help them in other aspects of healthcare and can reduce those overall costs. And so it's an area to look at for whether or not there are interventions that might be able to accomplish that. Again, observational data. In the nursing home, there's the minimum data set. This is another widely used observational data set in health services research, looking at illnesses in elderly, institutionalized, skilled nursing facility patients. And another source of great data. One of the things that the minimum data set does is it's not just claims data. Where Medicare is claims data, and the breadth of information is wide, the depth is very shallow. When you get into something like the minimum data set, it's actually data that's being collected by the facilities and reporting to Medicare. They have to fill out a questionnaire. And so you can get more in-depth information about the psychiatric condition of patients and other things that are happening in that home. Falls that happen, those kinds of things are all being tracked. So it's a very rich data source. Survey and claims. There's the current Medicare beneficiary survey. This is a survey that's done of a sample of patients that are Medicare beneficiaries, and it's then matched up to their claims. So there are opportunities here and there where you can get some of that deeper information and not just the breadth of the information that's out there. Oops. Quality. So we've been talking mostly about access and utilization and cost in some of these other observational studies. There are also lots of studies that look at quality. So there were several studies that looked at preventable medical errors that happen in facilities, looking at safety issues and quality of care. And these are just a couple of examples that you could take a look at. The Institute of Medicine report, To Err is Human, estimated that there were it was $2 billion per year in inpatient hospital costs due to drug errors. And so there were a couple of studies that were done on using different interventions to reduce medication error in the hospital facility. And so we have some examples of what those look like by David Bates. And so these are the kinds of things that can be done with, it is an intervention study, but you're using the databases within the facility in order to take a look at what your endpoints are. I wanted to slip this in here just because in health services research, we talk a lot about cost, quality, and access. And I think one of the things that's happened in the last few years is there's been much more of a focus on quality, especially with the To Err is Human report. And there's much more of a focus on quality from the CMS perspective, because CMS is paying all of these enormous bills for the Medicare and Medicaid system, and they always want to know what they're getting. They also have been paying traditionally fee-for-service. And in the last 10 years, there's been this evolution at CMS in no longer paying for volume, but paying for value. And so Medicare and CMS have implemented quality programs to start to do this evaluation of what is the quality of care. So they have the inpatient quality reporting system. It's happening inside hospitals. They have the PQRS, the physician quality reporting system, happening in outpatient physician offices. These are things that have been implemented by CMS to actually look at the quality of services. And if there are programs that are now looking at value-based payment, if an organization isn't meeting particular quality thresholds, or if they're falling out of the norm, they can actually get a 1 to 2% reduction in their annual payments for doing that. Or if they're falling very high level, they could get a bonus. They could get a 1 to 2% bonus. You think, well, 1 to 2%, that's not much. 1 to 2% to the hospital down the street is a heck of a lot of money. It's a lot. So they're really conscientious about it. And I'm sure you've probably heard of the 30-day readmission policies. For certain conditions, CMS will no longer pay for a 30-day readmission. If that patient was discharged by your facility and they're back in the hospital for within 30 days for any reason, and they were hospitalized for a certain set of diagnoses, you're going to lose payment for that patient, and you're going to take a hit. And that 1 or 2% over time really starts to add up. So where do these measures come from? The measures come from everywhere. They come from all over. CMS develops the measures. Medical societies develop the measures. AMA has an office, a branch, that develops measures. So how do we know the measures are good? How do we know that the measures that have been developed by someone are any good? One way is that they go through an endorsement process with the National Quality Forum. So the National Quality Forum is the good housekeeping seal of approval for quality measures. And those typically are the measures that CMS will use in their programs. They try to use measures that have been endorsed and not use measures that have not been properly validated and tested. This is an area of research that's getting a lot more attention in health services research, because people want to know, the clinicians want to know, and the payers want to know how good are the measures at actually capturing quality. And patients want to know, if I'm going to make a decision on which hospital I go to based on the measurement that shows up on CMS's Hospital Compare website, I have to be able to interpret those numbers. And this is a big area where a lot of health services research is going on. So some resources for you. You can look at Academy Health. There's lots of information about health services research there. ARC, of course, because they are the main funding agency in this area. PCORI as a new funding agency in this area, mostly focused on patient-centered issues, patient-focused drug development, patient engagement issues. Are we engaging patients properly in the research before the research begins? And then some of the journals, Health Services Research, Health Affairs, Medical Care. And that's me. I'm in the School of Pharmacy, and happy to answer any questions. I know, I blew through that really fast, didn't I? I'm the only thing between you and this beautiful day outside, so I wasn't taking any chances. Any questions? Any questions? I know you got the slide deck on patient engagement and patient-centered outcomes research. Any questions on that? I can also handle that for you, too. We have a couple of projects on campus that are very CER P-Core focused. We have on campus, we have a CER P-Core work group. It meets in the summer. It's meeting once a month. Our next meeting is August 20th. During the winter, when everybody's back in session, we meet every 2 weeks. You can phone in by participant call-in, or you can come to the meeting. It's a group that's established on campus so that researchers can help one another in terms of getting PCORI grants. Bring an idea for a grant, bring an idea for a project. You can find collaborators. You can find people who will read your proposal for you and give you comments on it. If you have questions about whether or not you think a topic is something PCORI would undertake, you can get feedback on that. So we have that is going on right now. You're welcome to send me an email. Let me know if you want to join the list. We have a CER P-Core website. It's very messy right now, but in September we will be unveiling our new CER P-Core workgroup website that will have all of the information about us, about what we're doing and opportunities. We have a new Ph.D. program that's just being started on CER P-Core in the School of Pharmacy in my department. And that's just getting off the ground. Because of that, we have some new courses that we're offering. This September, we're offering Introduction to CER P-Core. In the spring, we'll be offering a Quality and Quality Measurement course. And then the following spring, 2016, we'll be offering a Health Outcomes course focusing on how to measure outcomes, patient-reported outcomes, clinician-reported outcomes, observer-reported outcomes, and clinical outcomes. So lots going on in CER P-Core on campus. And in my view, CER P-Core are not any different than what I was doing at ARC 20 years ago. It just has a new name. Back then we didn't have millions of dollars, billions of dollars that they're putting into it now. So you can change your name if you've got billions of dollars.
In your division, the Pharmaceutical Health Service Research, Health Services Research, is that like a specific focus than general health services research?
Yes, because we're in a School of Pharmacy, we're Pharmaceutical Health Services Research. Our dean kind of likes it that way. But we do lots of general kinds of things. We have about, I think there's about 15 people in our department now, and we have a real mixed bag of what people work on. So we have some people who are working on mental health issues in children. So we have some big projects going on in that. We have opioid abuse and programs for reducing opioid abuse. Dr. Bruce Stewart, who I showed you a couple of his papers, he's probably one of the leading researchers in the country when it comes to using the Medicare databases, the Medicare claims databases. I can't even tell you how many publications he has in that area because a vast number. Dr. Mullins is the head of patients, and don't ask me what patient stands for. It's another acronym, but it has to do with patient engagement and engaging. And actually, it's an infrastructure grant from ARC at helping to engage patients and developing that infrastructure so that patients can become more involved in research and have more ability to participate and have their voice heard. So he's working on that. I will announce to you, even though it's not known to everybody yet, but I, in the last 2 weeks, signed an agreement with Optum Labs. Optum Labs is kind of a think tank. They call it the Sandbox. It's a think tank that is an arm of United Healthcare, and we will have access to 150 million lives of claims data from United Healthcare, along with 40 million lives of electronic medical record data that comes from Humedica. And we also have access to AARP data through this agreement. And the AARP data is survey data, it's their insurance data, all those kinds of things that the AARP does. And then last but not least, it also gives us a link with Mayo, and we'll have access to Mayo records, Mayo Clinic records. And so anybody who's interested in hearing more about that, I can tell you more about the databases that we're going to have access to very shortly, because the agreement's been signed. I and my postdoc are going through training tomorrow, and there'll be some more training that will happen in the next month. And then we will have access to it, and people who want to write proposals, people who want to, or who have some kind of funding and want to tap into this, it's not free. We don't have access for free. We have special access through this agreement, but we have to pay our way for for things that we need for them to do runs on for us. So it's a mixed bag. We have a lot of people doing a lot of, and I probably didn't even scratch the surface of half the people in the department.
Thank you.
Thank you.